Welcome to the Clinical Update Podcast, the podcast that brings you thought-provoking clinical education from MIMS Learning that you can fit into your busy life. My name is Dawn Liz Powell, Medical Editor at MIMS Learning. Here in the studio with me are my colleagues.
I'm Pat Anderson.
And I'm Sangeeta Krishnan.
Today we will be talking about chest pain, looking at its possible causes and management options. But before we get into that, let's get the obvious out of the way. Chest pain can be a sign of myocardial infarction, and if a GP suspects that myocardial infarction or another life-threatening cause is causing the chest pain, immediate referral to A&E is warranted. This discussion will be more focused on chronic chest pain that can at least partly be managed in primary care. In our red flags module on chest pain, Dr. Pipin Singh notes that chest pain is a common presentation in primary care. He says it can have many different causes and this can make identifying the cause difficult.
Okay, so chest pain can have many different causes, but wouldn't the heart be a good place to start looking for a cause? Because even if myocardial infarction has been ruled out, the patient could still have a cardiac cause, like stable coronary artery disease.
Yeah, I would have thought so, but I think that would very much depend on the patient's risk factors. For example, coronary artery disease, or CAD for short, may well be the cause of chest pain in an obese 60-year-old with type 2 diabetes, but I presume it's less likely to be the cause of chest pain in an otherwise healthy 20-year-old. I think this is where a good history taking might come in.
Yeah, so in the red flags module that we were just talking about, Dr. Singh recommends starting with an open question, such as, tell me more about the pain, which should reveal more about its features and thus help GPs move towards a diagnosis. He provides a useful list of other questions to ask, such as whether the pain occurs at rest and whether it radiates anywhere else. CAD is an obvious cause to look for and, as GPs know, is caused by atherosclerotic narrowing of the coronary vessels. Slow progressive narrowing results in angina, which is discussed thoroughly in a clinical review on ischemic heart disease by cardiologist Dr. Sukhjinder Niger. He provides some useful guidance on presentations of angina, including that many patients will describe a sensation of tightness or pressure rather than pain, that angina pain typically lasts 2 to 5 minutes and is neither fleeting nor longer than 20 to 30 minutes. Not all patients have radiation, but angina pain tends to go across the chest rather than being isolated to a single location.
Yeah, I also think it's worth mentioning that historically there's been a misconception that CAD affects women and men differently. Women with CAD did not present with chest pain, but actually in her module on CAD in women, Dr. Aisha Gohar comments that women are just as likely as men to present with chest pain. However, she does say that women tend to describe a more widespread radiation of the pain than men. Dr. Gohar also states that there tends to be a longer delay between symptom onset and presentation to hospital in women with chest pain. While women with chest pain are more likely to phone their GPs earlier than men, there is a delay on the GP's part, a delay that's not seen with men.
That's interesting. And another thing I note that Dr. Gohar says that's, again, interesting, perhaps worrying, is that an angiogram that's used to help diagnose CAD can only see vessels that are above a certain width in diameter. So this means it can't see the microvessels. And according to Dr. Gohar, this can be an issue for women because they're more likely to have coronary microvascular dysfunction than men. So potentially a woman with microvessel dysfunction could be diagnosed with non-cardiac chest pain because the angiogram didn't pick it up. And in fact, about half of women with non-cardiac chest pain may actually have microvascular dysfunction. This means they're not getting interventions for CAD and are thus at an increased risk of an acute coronary event.
Okay, so this sort of leads us on to the management of CAD, which we'll briefly go over. I know, Pat, you've just mentioned acute events, but let's focus on stable disease because, again, at least partly that will be managed in primary care. So as far as I understand it, the goal with managing stable CAD is to prevent progression, that is, reduce the risk of an acute event, and to relieve the symptoms of angina. Dr. Niger says that management includes lifestyle advice, medications such as statins to reduce the risk of progression, medications for symptom relief such as beta blockers, and revascularization.
So obviously encouraging patients to stop smoking if they do smoke and eat a healthy diet is important, but when I read that module, I was surprised to learn that people with CAD need to be careful about exercising. Dr. Nijar writes that patients should be advised to avoid sudden increases in exertion because that could trigger an event until after medical therapy or revascularization.
And as GPs will be aware, revascularization can either be in the form of coronary artery bypass grafting or CABG, or through percutaneous coronary intervention or PCI. So while revascularization, specifically PCI, is a first-line treatment for acute CAD, its use in stable disease has been controversial. So according to the NICE guidelines for managing stable disease, PCI should only be used for stable disease when symptoms are not satisfactorily controlled with optimal medical therapy. So, however, as discussed in a conference report that we've created from the 2024 British Cardiovascular Society Annual Conference, the Orbiter study, which was published after the NICE guidelines, found that PCI did not provide a symptom benefit compared with a sham procedure in people who are on optimal medical therapy. So Dawn tells me this issue has led to cardiologists having some very interesting professional discussions on social media. So that said, Dawn advises me that studies do suggest that PCI or CABG has a role in people with complex disease. And also a follow-on Orbiter study has found that PCI had a role in those with stable disease who are not on anti-anginal medication.
Okay, so that's a fair bit of info on stable disease being a cause of chest pain. Before we move on, other causes of cardiac-related chest pain, according to Dr. Singh's red flags module, include pericarditis, myocardial infarction, aortic dissection, and valvular heart disease. Dr. Singh categorizes myocardial infarction, aortic dissection, and valvular heart disease as life-threatening. In particular, myocardial infarction and aortic dissection are medical emergencies. Aortic dissection, as a recap, is when there is an injury to the innermost layer of the aorta, allowing blood to flow between the layers of the aorta. Its symptoms are actually quite similar to those of a myocardial infarction, which unfortunately can lead to misdiagnosis and mismanagement. I would recommend reading our module on aortic dissection, as that does give an overview of how to differentiate between aortic dissection and myocardial infarction.
Hi, I'm Chloe Harmon and I'm the editor of MIMS, which provides prescribing information and tools that complement the brilliant educational modules on MIMS Learning. You might already know that MIMS provides a database of concise summaries of prescribing information for more than 3,000 medicines. We also offer a range of other resources to support your prescribing, such as our drug comparison tables covering topics like HRT products and switching antidepressants, our product trackers, including our highly popular drug shortages tracker, and visual guides to diabetes and respiratory devices, which are especially useful for healthcare professionals running clinics for these conditions. Of course, we also bring you all the important news and updates affecting your prescribing practice, which you can receive straight to your inbox in our email bulletins. As a healthcare professional, you're entitled to limited free access to MIMS online simply by registering. And of course, if you or your organisation subscribe, you receive full, unlimited access to the whole range of MIMS resources. To find out more about MIMS, visit mims.co.uk.
Let's move on to the non-cardiac causes of chest pain. What indicates chest pain might have a non-cardiac cause?
So in its guidelines on chest pain of suspected cardiac origin, NICE says stable CAD is unlikely to be the cause if chest pain is continuous or very prolonged, unrelated to activity brought on by breathing in, or if there are symptoms like dizziness or difficulty swallowing. To be clear, this is when an acute coronary event has already been ruled out and there's little clinical suspicion based on the patient's history and risk factors that they have CAD. But of course, even if the chest pain does not have a cardiac cause, it could still be a sign of a life-threatening condition. Dr. Singh lists several non-cardiac life-threatening causes of chest pain, including lung cancer or GI perforation.
That's a good point, though I think given those conditions probably wouldn't be managed in primary care. Let's focus on the non-cardiac causes of chest pain that, at least partly, are investigated and managed in primary care. So both NICE and Dr. Singh mention gastroesophageal reflux disease, or reflux for short, as a potential cause of non-cardiac chest pain. I have this actually, and this is because of a hypermobility-related sliding hiatus hernia. I'm not really sure what that is, to be perfectly honest. I just know that if I drink orange juice, I will feel like acid is burning a hole in my chest half an hour later.
I had heartburn during both my pregnancies, and I remember that feeling all too well. Our red flags module on dyspepsia or indigestion, it says that reflux may be exacerbated by lying down. Similar to what you just said, Dawn, patients may report having an acidic taste in their mouth.
Yes, I certainly find that my reflux is worse when I lie down to go to sleep. I personally find that sleeping my left helps. NICE doesn't actually mention sleeping positions in its reflux guidelines, but it does say that raising the head of the bed and having a main meal well before going to bed may help some people. I've got to be honest, I think my reflux would be better if I didn't have my tea or dinner so late at night. The guidelines also say that people should be advised to avoid anything that they know might trigger their reflux, such as alcohol, coffee, chocolate and fatty foods. And as always, people should be encouraged to lose weight if they're overweight and to stop smoking if they smoke. In terms of medication, NICE mentions offering empirical full-dose PPI therapy for 4 weeks to people with dyspepsia. If symptoms return after initial care strategies, NICE says to step down PPI therapy to the lowest dose needed to control symptoms. Healthcare professionals should then discuss using treatment on an as-needed basis with people to manage their own symptoms. Okay, so we have discussed reflux as a non-cardiac cause of chest pain. What other causes of chest pain are there? I can personally attest that breathing in a load of anti-mold spray when you're demolding the bathroom can lead to pneumonia and consequently chest pain.
You really need to wear a mask when you use those products, Dawn.
Yes, I know that now.
So yes, we all need to remember to open the windows when doing those household tasks like cleaning the oven. But respiratory causes of chest pain do come into the picture, obviously. Dr. Singh's red flags module lists potential respiratory causes of chest pain, including lung cancer, as mentioned, pleural effusions, pneumonia, pneumothorax and pulmonary embolism. Just as an aside, he also adds that significant anemia may also be a cause of chest pain. Chest discomfort can also be a feature of interstitial lung disease, which we have a clinical review on, and that's really an umbrella term for a range of conditions, from asbestosis to what's known as hot tub lung, that can occur as a result of multiple causes.
Yeah, and in fact, NICE says that when considering a diagnosis of COPD, clinicians should ask about chest pain. However, our module on the GOLD guidelines on COPD notes that breathlessness is the cardinal symptom of COPD. So perhaps while COPD can cause chest pain, it's the breathlessness rather than the chest pain that will prompt someone to seek medical attention. I think this may also be true of valvular heart disease, which you mentioned earlier, Dawn, as being a potential cause of chest pain. In our clinical review of aortic valve disease, the authors note that this condition can be difficult to diagnose, as the signs and symptoms may be confused with the general signs of aging. In fact, aortic valve disease may even be asymptomatic. So perhaps again, chest pain can be a symptom of aortic valve disease, but it wouldn't necessarily be the presenting one.
So if we're focusing on conditions that have chest pain as the presenting symptom, Dr. Singh says that psychological factors, for example, extreme anxiety, can cause chest pain. And he says not only can anxiety be a cause of chest pain, but also chest pain can cause anxiety. If GPs do suspect that anxiety might be the cause of the chest pain, they should ask the patient if they have other features of anxiety. For example, if they have difficulty sleeping or if they're feeling on edge.
If anxiety is diagnosed, according to a module we have on generalised anxiety disorder, NICE recommends a stepped care model for management. In this model, the least intrusive and most effective interventions are offered first. So essentially, the initial management steps are educational anxiety and advice on guided self-help. Psychological therapies and drug treatments can be offered if those initial strategies do not resolve the symptoms of anxiety. Actually, have a listen to episode 5 of season 3 of this podcast as we do discuss our anxiety module more in depth there. Thanks for discussing the possible causes of chest pain with me, Pat Sangeeta. To recap, we've looked at CAD, reflux, and anxiety as causes of chest pain. But what are your takeaways from this discussion?
So I thought it was really interesting that about half of women whose chest pain has been diagnosed as having a non-cardiac cause may actually have microvascular dysfunction, but an angiogram hasn't picked it up. So this means that they potentially have some degree of CAD but are not getting interventions for it, and thus perhaps are at increased risk of an acute coronary event.
My takeaway is that if chest pain is continuous or very prolonged, unrelated to activity, brought on by breathing in, and if there are symptoms like dizziness or difficulty swallowing, CAD is unlikely to be the cause. But of course, that depends on what the patient's other risk factors and symptoms are.
Mine is that psychological factors, for example, extreme anxiety, can cause chest pain. And not only can anxiety be a cause of chest pain, but also that chest pain can cause anxiety. Thank you so much for listening to this episode. We have been the MIMS Learning editors, and our producer was Till Owen. All of the modules we discussed will be listed in the podcast notes. If you are listening to this episode on your podcast player, we do recommend heading over to the module version on MIMS Learning, as you can download a CPD certificate there for a suggested 0.5 CPD hours. Do join us next week, which will see Pat interview Dr. Pippin Singh about managing the needs of people who live in nursing homes.